Good morning, students. So the topic of today's presentation is, I will be dealing in classes, diabetes and its pharmacotherapy. So why we have chosen diabetes and its pharmacotherapy? Because it is one of the most essential topics that we have to deal in the common lifestyle disorders, as well as all the things which is happening in the common life. First of all, in this particular topic I will be mentioning about diabetes. So if I have to talk about diabetes, diabetes is one of the most common metabolic disorder that share the common phenotype of hyperglycemia. What does it mean? It means increased blood glucose level. Whenever the blood sugar level rises beyond the increased amount, it is called as diabetic condition. And it is the major harbinger for a number of serious medical conditions, and as a result of which it contributes to basic two complications. One is the microvascular complications and second one is the macrovascular complication. In microvascular we are dealing about the smaller blood vessel, that's why the word micro comes into the picture, and when we are talking about the larger blood vessels, it is called as the macrovascular complication. In microvascular complication, it mainly includes retinopathy, neuropathy and nephropathy, while in macrovascular complication, some of the coronary artery disease complication and stroke occurs. So diabetes is that much important disease in today's life. Why? Because from the year 1980, the data which was obtained from the various scientific resources estimated that it is about 108 million. But in 2014 year, that data progressed approximately 4 times. It multiplied 4 times and it increased to 422 millions. And epidemiological data suggests that by the year 2035, the rate would be approximately, the persons who would be afflicted with this kind of serious disorder, that is diabetes, will be 492 million. And because of this alarming data, the country of ours, India, has gained the diabetic capital of the world. Means in the world, our country has gained the status of the diabetic capital in the current scenario. So this is the major concern, and that's why all the current strategies, all the current medications are being focused on eliminating this particular disorder. So now coming to the type of diabetes, if I am talking about some type of diabetes, it is broadly classified into 2 types. But yes, there are 4 major types of diabetes. But yes, if we are talking about superficially, we can classify into 2 main types, that is type 1 and type 2 diabetes. Coming to the type 1 diabetes, which occurs usually in the childhood, and it is affected by hereditary, and sometimes in this type of diabetes there are no symptoms. And in this type of diabetes progression, when it progresses, there is the destruction of pancreatic beta islets. So the beta islets, beta cells that produces the insulin, that gets destructed. So there is practically no insulin available. In this, there is always imperative to inject insulin daily, and it is also called as the insulin needed group. Why it is called as insulin needed group? Because insulin is mandatory for the persons to be administered, and that's why the symptoms will increase. And the patients who are having prone to this particular disorder, they need insulin daily to survive. So then is the type 2 diabetes mellitus, which is the most common type of diabetes mellitus and which usually occurs in childhood. But now the current scenario is that the cases are coming in which it progresses to the younger generation also, and it affects many children also. And in this, the beta cells don't get destructed, but there is abnormality in glucoreceptor of beta cells, and there has been the increased propensity to obesity. So normally what we have studied, that diabetes is basically of 2 types. First one is the type 1 diabetes mellitus, and second one is the type 2 diabetes mellitus. Type 1 diabetes mellitus, insulin is mandatory because beta cells which produces insulin, they get disrupted. But in type 2 diabetes mellitus, there is abnormality in beta cells, as a result of which insulin will be available there. In type 1 there was no insulin available, but in type 2 diabetes insulin is available but it is not able to respond. Third type is the gestational diabetes. As the figure indicates here, that it occurs basically in the pregnancy times, and women who give birth to children over 9 pounds, they are having this type of problem of diabetes, and there might be a complication that can progress further, that can lead even to the cardiovascular diseases. The fourth type of diabetes is pre-diabetes. Normally there is a fluctuation between there is always a dilemma that whether the person can be considered into the diabetic group or the non-diabetic group, and approximately 79 million people are diagnosed with diabetes each year. And now the average blood glucose levels they are not high, they are not low, they are not high, means they are at the borderline, which creates always a dilemma among the physicians to distinguish between which type of category of diabetes it is. So it is considered as a pre-diabetes, and it starts with unhealthy eating habits and inadequate exercise. For there are some sort of which you call as the personal habits, or you can say at the dietary modifications, sedentary lifestyle we are living, then we can progress even to the pre-diabetes stage. Then some other type of diabetes apart from these 4 types of diabetes, that is type 1 diabetes, type 2 diabetes, pre-diabetes and gestational diabetes. There are some other types of diabetes, in which first is the maturity onset diabetes of the young, which is also called as the MODY, and which occurs because of the mutations in the gene. There is the mutations in the gene which produces the insulin. So insulin is the basic hormone which produces the insulin. When it is produced, what it can do, it always regulates the blood glucose level. It causes the glucose level to be in the controlled limit. So if there is disruption in the gene of the insulin, that the insulin level will be less, and it is also referred to as monogenic diabetes. The second is the LADA, which we called as it is abbreviated as LADA, and its full form is latent autoimmune diabetes of adults. From the figure you can see that above the figure it is type 1 diabetes and below the figure it is type 2 diabetes. Why? Because some of the symptoms that occurs because of the type 1 diabetes, it seems that it is type 1 diabetes, and some of the symptoms can occur because of the type 2 diabetes. So basically, normally the type 2 diabetes, which is the prone cause of the progression of the complication, that is also being responsible in this type of LADA diabetes. Then what are the symptoms? There are majority of the symptoms which progresses in diabetes. I told you earlier in the lecture that diabetes is that much serious complication nowadays, that because of the modern lifestyle and the things that we are adapting from today's life, like we are eating fast food, we are not doing exercise, so that is contributing a lot to the progression of diabetes. And it is that much severe problem that it has a varied number of symptoms. Some of the symptoms, like if I have told about like microvascular complication, there is blurred vision, and it progresses to retinopathy. There is fatigue, right? So among those, there are painful micturition is there, sores, bed sores, that the person are having the bed sores problem. So there are the varied number of symptoms which occurs because of this giant problem of diabetes, among which the most prominent are the blurred vision, fatigue, thirst, painful micturition, that is and frequent urination, right? Sores that do not heal, nausea, vomiting, weight loss, hunger, and the basic problematic thing is in some cases there are no symptoms. So normally what is happening, that normally diabetes type 1 and type 2 symptoms are almost similar, although the symptoms of type 1 diabetes are more worsened. So what happens when there is no diabetes? See, this is the pictorial presentation. It is evident from this type of picture. It is the normal cell, and here I am telling and I am progressing that insulin is like the key, like a normal key can open the lock. So in this case, what happens? Sorry for the interruption. So insulin is like the normal key in which basically a normal key fits into the lock and the locks get open. So from this diagram it is very much evident that in the normal cell insulin is like the key that opens lock, so glucose can enter the cell. Once glucose can enter the cell, it can cause the reduction in the blood glucose level. That is what our aim was, that we have to reduce the blood glucose level in the body, right? So what we do, insulin controls the rise in blood glucose level by stimulating the glucose to go into the cells, because now insulin has opened that lock. That's why the glucose can go into the cells and tissues, and thus it lowers the blood glucose levels, and it prevents the liver from putting out into the bloodstream extra glucose. The extra glucose which was available there, that has been reduced now, and it prevents the pancreas from putting out the glucagon, which lowers the blood glucose level. Then it is type 1 versus type 2 diabetes. It is again a very beautiful diagrammatic presentation which will clear the concept here, that in type 1 diabetes cell, like in the previous slide I told you that insulin is like a key which can open the lock, and thereby when the lock is open, the blood glucose level can go into the cells and tissues, thereby the blood glucose level gets lowered. In this type of diabetes, type 1 diabetes, there is no insulin, there is no key. So if there is no key, the lock can't open, right? So means the sugar cannot enter the cell. It can't enter the cell, it remains there in the blood, and thereby the blood glucose levels get enhanced. In type 2 diabetes, there is insulin, there is key available, but here it is not fitting into the particular lock. That's why it is the insulin is present there, but it is not available to open that particular lock. So insulin resistance condition occurs, that insulin is present there, but it is not able to exert the hypoglycemic action. Then there are some sort of very important facts that I would like to mention here, because that will create some very basic understanding why it is being emphasized that much here, that diabetes has gained the India has gained the diabetic capital of the world status, and why diabetes is that much problematic thing. Because in every 24 hours, whenever it is happening, in every 24 hours 4,557 adults are being diagnosed with diabetes. And the story doesn't end here. See the data which has been taken from a National Diabetic Status Report 2014. It is saying that in every 24 hours 641 people are dying because of the diabetes, or it can occur because of the complication that diabetes is causing, and that is creating the death. And 136 people begin treatment for end-stage renal disease because of the complication that occur over to the tubules, kidney diseases that occurs. So there are some sort of the diagnostic tests that are very, very important, because we have to diagnose that whether the patient that is being affected with diabetes, that person is really affected with diabetes, or the story is something else, or there are some sort of symptoms which are occurring but diabetes is not the cause. So we have really to rule out the test, and we have to really to rule out whether diabetes is occurring, and that can be diagnosed with certain tests. So these are the tests. First one is the fasting plasma glucose tolerance test. So what happens in this test? No food or drink 8 to 12 hours prior to test. Suppose we have to administer we have to administer this particular test to particular patient. So what we have to do? We have to remove the food or drink 8 to 12 hours prior to this particular test, and then blood is drawn and tested for the level of blood glucose level. If the blood glucose level is high, it determines that there is the chance of diabetes. Second is the oral glucose tolerance test. So again in this test, no food or drink 8 to 12 hours prior to test. Before test 8 to 12 hours, we need not to administer any sort of food or drinks to the patient who is going to be having this particular test, oral glucose tolerance, that is OGTT test. And then the patient is supposed to drink glucose, and then blood is tested after 2 hours of the glucose administration, and if there is a high blood glucose level, then it determines the potential diabetes condition. Then glycosylated hemoglobin. See here I would like to mention this is the red blood cell. It is the sugar. So in both the figures, in this particular figure, there is more amount of the sugar that has been attached to the red blood glucose cell molecule as compared to this. So glycosylated hemoglobin is again an important index of the measurement of the blood glucose level that indicates that the amount of glycated hemoglobin in the blood. And glycated hemoglobin is a substance in red blood cells that is formed when blood glucose attaches to hemoglobin. When it gets sugar attaches to the red blood cell, the glycated hemoglobin level will rise, and that will indicates again the diabetic condition in the patient. So this is basically a tabular representation that will more clarify the concepts, that if there is a normal patient, HbA1c is about 5%, 99 fasting plasma glucose and OGTT 139 or below. In pre-diabetes condition, that is the four major common type of diabetes, in which there was type 1 diabetes, type 2 diabetes, and then pre-diabetic and gestational diabetes. In pre-diabetes, if it is HbA1c count is about 5.7 to 6.4, it is pre-diabetic condition. If the fasting plasma glucose level goes from 100 to 125, then it is fasting plasma glucose, and if it is more than 140 to 199, it is oral glucose tolerance test. And in diabetes, it is 6.5 or above, it is 126 or above, or it is 200 or above. So till now I was talking about diabetes, its complication, what are the various symptoms that has been caused to a patient because of diabetes, and what are the basic features or the diagnostic test, you can say, that can be used for the scrutinizing the patient from the non-diabetic to a diabetic journey, that how that person has progressed from non-diabetic to diabetic, and what are the tests that one can do for testing this type of disorder. So now coming to the major concept, that is management of diabetes, how it is being managed. Now I will focus about the treatment measures of diabetes. So now is the diabetes management. I will abbreviate it with diabetes DM, diabetes management. So in basic this three components come. First is the diet and exercise. Second is the insulin therapy. Third one is the oral hypoglycemic agents. So basically the treatment or the management of diabetes falls in these three categories. First one is the diet and exercise, that the person has to do the diet control plus he or she has to do the exercise also in order to control the diabetic condition. Second is the insulin. As I told you, in type 1 diabetes no insulin was there, so insulin was basically very important for the person to administer, and in type 2 diabetes insulin was there but it was not able to respond, so there is basically the need to enhance that insulin responsiveness. Then is the oral hypoglycemic agents or the drugs that we give to diabetic patients. So coming to the first part is diet. Diet is a basic part of management in every case. Like if our diet is good, our body is free from many kind of diseases. If our diet is containing certain kind of things which are not beneficial for the body, or that is going to create some kind of problems, that is also ending up the body into a number of devastating problems. So dietary treatment should aim at ensuring weight control, providing nutritional requirements, allowing good glycemic control. Good glycemic control means blood glucose level should be in the normal limits, and correcting any associated blood lipid abnormalities. Then exercise, which is equally important, as I mentioned in that particular point, that diet and exercise is very important, and which are the primary things that a person can do without you can say the medical treatments, right? So exercise includes physical activity that promotes weight reduction and improves insulin sensitivity. Then normally exercise should be considered for each person, like exercise is important for every person regardless of the age, sex, right? And normally these patients should be monitored for health status and fitness, and they should be treated about, and they should be educated about the potential risk that can occur because of the hypoglycemia. Their blood glucose level should not lower down to that much considerable amount that it can cause some sort of problems because of the hypoglycemia. See, there are two words in pharmacology, one is the hyper and second one is the hypo. When the word hyper comes, it corresponds to increased level, and when the hypo level comes, it corresponds to the decreased level. And if the hypoglycemia has occurred, that is, blood glucose level has reduced drastically, and what are the measures that needs to be taken in order to avoid that? Because there are complications which can occur because of hypoglycemia conditions also, and it can even lead to coma and death of the patient. So coming to the second point, that is insulin therapy. Now I will be talking about insulin therapy. Insulin therapy is basically a major, you can say, what you call it, the major advancement in the diabetes therapy. But before discussing over this, we have to know what is insulin basically. So insulin is nothing, it is basically a peptide hormone produced by beta cells of pancreas, and it basically plays a role in the regulating carbohydrates and fat metabolism, and it causes the absorption of the glucose. And when the insulin level is low or insulin is present but it is not able to respond, then diabetes mellitus can result. So what I have told you about insulin, just I want to mention it here because it is very important. Insulin, it is basically a hormone which is produced by beta cells of pancreas, right? And what is its most important function is regulation of Bg level. Bg corresponds to blood glucose level. If insulin is present, then blood glucose level is controlled, it gets absorbed, glucose gets absorbed. And if blood glucose level is high, it means insulin is either not responding, or if it is responding, there is some problem of insulin resistance, or the insulin is not present at all. So structure of insulin is basic a chain of two disulfide bridges, right, and in which it consists of 51 amino acids. How 51 amino acids? Because A chain consists of 21 amino acids and B chain consists of 30 amino acids. 30 plus 21 is 51 amino acids, and its T half is approximately 5 to 10 minutes, and it is degraded by insulinase, which is also called as glutathione insulin transdehydrogenase, that leaves the disulfide links. These disulfide links gets broken by insulinase enzyme. So normally the human insulin differs from bovine insulin by 3 amino acids and pork insulin by 1 amino acids. And insulin is stored as a complex with zinc ions. How insulin is biosynthesized? I told you that it is a hormone which is normally produced in the body. So it is basically being produced as a pre-proinsulin, and in the endoplasmic reticulum it gets converted into the proinsulin, and then it gets converted to insulin. And as I mentioned in the last slide, that it was having 51 amino acid chain. So 21 plus 30 is 51. So insulin once formed from pre-proinsulin, then proinsulin, then insulin. So it is ultimately a 51 amino acid chain having disulfide linkages. Then what is the mechanism of action of insulin? Insulin basically acts on the insulin receptors which are present on the cell membrane, and it is a heterodimer in which basically a tyrosine kinase receptor, and in this there are two subunits. First one is the alpha subunit and beta subunit is this. So alpha subunit, what is its property having? It is having the insulin binding site. It is having that particular site where insulin gets attached. So beta subunit is having the ATP binding and tyrosine kinase domain activity. So what insulin do when it attaches to the alpha subunit, it gets or stimulates the glucose transporter. See, what is the role of transporter? Anywhere if we are talking about the layman, transporter is the substance or agent which transports something. So if I am talking about the glucose transporter, it clearly indicates that it is transporting glucose here, right? Then there are certain type of messengers like tyrosine phosphorylated. So binding of insulin to insulin receptor causes the transmigration or you can say the phosphorylation of the receptor, as a result of which the insulin receptive substrate gets attached and it causes the glucose translocation. Glucose get entered into the cells and tissues, as a result of which the blood glucose levels get lowered. And over a period of time, insulin also promotes the expression of genes which direct the synthesis of GLUT4, again glucose transporter. Then insulin is basically distributed extracellularly and it is a peptide and it gets degraded in the GIT if given orally. Very important point is insulin can't be given orally because it's get degraded. So what you have to know about it, that orally insulin can't be given, right, because it's get degraded. So it is being injected, or the injected insulin is primarily metabolized in the liver and to a smaller extent in kidney and muscles. And nearly half of the insulin entering portal vein from pancreas is inactivated in the first passage through liver, and that's why, because liver is the main site where it gets metabolized. So basically it is exposed to higher concentrations. How much? Approximately 4 to 8 fold of insulin than other tissues. And during biotransformation or metabolization, what happens that the two bonds that I have mentioned, that is A and B chains, right, they get separated because the disulfide linkage which was attaching both A and B chains, that get distorted and the two A and B chains get separated. Then these are the different type of insulin preparations. I have mentioned here in the table form because it is easy to recall that. So it is being classified into the rapid acting. Rapid acting means very quickly acting. Then it is classified into shorter acting. It is classified then again next class is intermediate and long acting. In the rapid acting, it is being classified into insulin lispro, insulin aspart, insulin glucagon. Then shorter acting, regular insulin, which is also called as the soluble insulin, and intermediate acting insulin contains insulin zinc suspension or lente or nitroprotamine hydrin and isophane insulin, and longer acting insulin contains insulin glargine and insulin detrimer. So in the rapid acting insulin, it means that its action is very rapid, as a result of which its duration could be smaller because it gets into the action into a very peak action is coming into a very smaller time, as a result of which it gets degraded very quickly. And in the similar manner here you can see that in the rapid acting insulin it is 3 to 5 hours, and from this longer acting it is approximately 24 or 20 to 24 hours. So there is always a difference between the duration of action in which it gets act, and it depends upon the action in which it shows the peak effect. Then there are certain type of adverse events which are occurring because of the insulin, like in this hypoglycemia, lipodystrophy, allergic reaction and edema occurs, and contraindication, non-selective beta blockers like propranolol or alcohol, oral contraceptives, diuretics are contraindicated. They are not given to the patients. Insulin is not given to the patient if the patient is already on these type of medications. So coming to the next category is oral anti-diabetic agents. We have talked about exercise and diet. We have talked about insulin. We have studied about the insulin mechanism of action, how it causes the mechanism and how it gets into the body by the insulin receptors which are present on the cell membrane, and what type of action it produces, right? So now we have to talk about the oral anti-diabetic agents, in which there are different class of drugs, in which first is the sulfonylureas, then metronidine, biogenides, thiazolidines and alpha glucosidase inhibitors. Coming to the first category, that is sulfonylureas, which is the most important common class of drugs and one of the oldest class of drugs, I can say this. In this it is being classified into the first generation, in which tolbutamide or chlorpropamide occurs. Second generation, glipizide, gliclazide, glibenclamide and glimepiride occurs. Then how sulfonylureas act? Sulfonide areas act basically through the sulfonylurea receptor 1 receptors, and they primarily augment the phase 2 of the insulin secretion. See, our main aim is to increase the insulin secretion, as a result of which it can decrease the blood glucose level. And for the sulfonylureas to act in an effective way, what is the most important thing, that 30% functional beta cells are essential, that at least 30% of the beta cells should be functional at that particular moment when sulfonylurea receptor will show, sulfonylurea can show their effect, right? And its minor action is decreased glucagon secretion. What is its extrapancreatic action? That it increases the sensitivity of peripheral tissues to insulin by increasing insulin receptors. The insulin receptors, if they are less, then obviously insulin is binded to a less number of receptor, it will show less effect. If it is binded to a larger number of receptor, by how? Because sulfonylureas increase the insulin receptors, right? So insulin gets binded to a larger number of receptor and the wider action can be attained. So the adverse events which occurs because of this is hypoglycemia, GI disturbances in which nausea, vomiting, metallitis, diarrhea, flatulence, weight gain, hypersensitivity, and they are not safe in pregnancy except one drug, that is gabapentin, chlorpropamide, cholestatic jaundice, dilutional hyponatremia, and abuse reactions. And the persons who are on these particular medications or conditions, they are not advised to take sulfonylurea class of drugs. Some of the patients like which are already allergic to the sulfonylureas, having the renal failure problem also, having hepatic dysfunction also, because in this the hepatic problems can also occur, and they are having the traumatic condition or major surgery. Pregnancy, I told you they are not safe in pregnancy except one drug which is gabapentin, which is the safer drug, and type 1 diabetes mellitus. In this, that they are not going to be beneficial. Then maclitidine analogs, they are quicker and shorter acting insulin releases, and repiglenide and etiquelenide are the major drugs which comes in this category, and their mechanism of action is same as sulfonylurea receptors, but they act on the sulfonylurea receptor type 2. So that acts on the sulfonylureas act on 1 and it acts on 2. They are used to control postprandial hyperglycemia, that is after the food, and they offer the problem of less hypoglycemia. See, main aim is to produce hypoglycemic, that is less blood glucose level should be there, but it should not mean that it can create the problem of hypoglycemia, because that can even be more fatal condition. So what is the advantage that is associated with it? That it causes hypoglycemia but less as compared to sulfonylurea receptors. So some of the adverse effects that can occur because of this are mild headache, dyspepsia, arthralgia, and headache. So biguanides basically acts on the suppression of hepatic gluconeogenesis, and there is enhancement of glucose mediated glucose disposal in muscle and fat. There is always the promotion of peripheral glucose utilization. See, if glucose is available and if it gets absorbed, right, or if it gets utilized, what does it mean? By enhancing anaerobic glycolysis, right? If it is present in the body and if it gets utilized, it means that more of the glucose level has been utilized somewhere and less of the blood glucose level is there. So it is always an advancement thing for us, it is always a beneficial thing for us, and it also inhibits the intestinal absorption of glucose and other hexoses, amino acids, and vitamins, right? So again, some of the adverse effects because of this kind of drug are biguanides, metformin, fenformin, anorexia, nausea, vomiting, diarrhea, metallitis, loss of weight, skin rashes, lactic acidosis, vitamin B12 deficiency, and in renal failure there is advanced liver disease, alcohol abuses, cardiac disease, pregnancy, renal failure patient are not advised to take this fenformin and metformin drugs. Then thiazolidine glitazones, in which rosiglitazone and pioglitazone basically occurs, and they are the selective agonist of peroxisome proliferator activated receptor, in which the abbreviation is PPAR gamma, and they get attached to PPAR gamma because they are the agonist for PPAR gamma, and when it gets binded to PPAR gamma, they activate the insulin responsive genes and regulate carbohydrate and lipid metabolism. See, if it is binding to PPAR gamma, it activates the insulin responsive genes and they sensitize the peripheral tissues to insulin, because now the insulin receptive genes or responsive genes are activated, and once they are activated, they do the work of sensitization of the peripheral tissues to insulin, and Once it is sensitized, it decreases the blood glucose level, and that blood glucose level lowering was the main aim. And how that has been caused? It is being caused by three mechanisms. First mechanism I would like to mention here is blood glucose level gets altered. How? It gets transportation, first mechanism. Second is the inhibit hepatic gluconeogenesis. Gluconeogenesis gets inhibited. Third one is the promote lipogenesis. If I am talking about first category, that is glucose transport into the muscle and adipose tissue, it gets transported into the cells and tissue, as a result of which the blood glucose levels gets lower. So it shows its effect. Second is hepatic gluconeogenesis is inhibited. Gluconeogenesis is the formation of glucose from non-carbohydrate precursors. If already the blood glucose level is increased, and if now in the condition that blood glucose level gets increased further by gluconeogenesis, then it can create more problem, because already blood glucose level was more, and now what we are doing, we are causing the more glucose production because of this process. So this process also gets inhibited, and it also promotes lipogenesis. That's why all these things leads to the decreased blood glucose level. So in this particular condition, blood glucose levels get decreased, and as a result of which the blood glucose level which was increased, and that was causing the diabetes mellitus condition, that get decreased by all these three conditions, right? So these are the primary three mechanisms of the rosiglitazone and pioglitazone, which are the activators for peroxidome proliferator activated receptor. So again, if these kind of drugs are very, very important drugs in anti-diabetic treatment, right? So they are also offered with certain kinds of adverse events and contraindications, and the majority of the adverse events which are happening because of this rosiglitazone and pioglitazone is weight gain. Then why? Because there causes the promotion of the lipogenesis is there, increased extracellular fluid volume, worsening of CHF, deposition of subcutaneous fat, mild anemic condition, hepatotoxicity occurs, but it is rare. And with rosiglitazone there is always the increased risk of fractures, especially in the elderly women. So it can be avoided in that, because it is a very prominent adverse effect with rosiglitazone. And the patients who are having already the concurrent medical conditions or morbid conditions like liver disease, CHF, pregnancy, and lactating mother and children, they won't be offered with this particular treatments. They should be avoided rather. Then is the alpha glucosidase inhibitors, in which acarbose, meglitol, and voglibose comes. So what is its mechanism of action? If it is alpha glucosidase inhibitors, the very first thing we should come in our mind is it should inhibit the alpha glucosidase, right? So what is alpha glucosidase? It is an enzyme which is present in the lining of cells of intestinal villi. So normally what happens, the dietary carbohydrate that we consume through diet, pancreatic amylase acts into it, and it gets converted to disaccharides or oligosaccharides like maltose, isomaltose, and sucrose. So once they are being formed, like oligosaccharides and disaccharides are being formed, alpha glucosidase comes into action, and it gets converted into the monosaccharides. From disaccharides, monosaccharides like glucose and fructose are formed, and they get absorbed in the lower part of the intestine. Now, if it gets absorbed in the lower part of intestine, then what will happen? The blood glucose level will get increased. So the primary role of alpha glucosidase inhibitors is to inhibit this particular stop. As the result of it, disaccharides will not be converted into the monosaccharides, and if it is not converted into the monosaccharide, the blood glucose level is not going to be increased further. So hypoglycemic effect will come into action. So glucosidase inhibitors inhibit this particular step. Then adverse event, again I told you it is a class of drug, very important class of drugs, but they are again at the same time they are having some sort of adverse events like flatulence occurs, diarrhea, abdominal pain, do not cause hypoglycemia by themselves, but may cause if they are used with sulfonide ureas. You might remember when I was talking about sulfonide ureas, I told you that they were causing some sort of hypoglycemic conditions. But if we are using alpha glucosidase, they cause more of this. If hypoglycemic occurs, should not be treated with routine sugar, glucose should be used, right? And for the patients which are already having the problem of inflammatory bowel disease or intestinal obstruction, they shouldn't be administered alpha glucosidase inhibitors. Then there are certain kind of newer drugs in which the GLP-1 analogs come, in which exenatide and liraglutide comes. Then DPP-4 inhibitors in which sitagliptin, betalagliptin, egliptin occurs, and amylins like pramlintide comes. Then coming to the first is exenatide. And exenatide, as I told you, GLP-1 analogs. What it causes? It causes the increase in postprandial insulin release. Once the food has been taken, it causes the insulin release to be occurred. Suppresses glucagon release. If glucagon is being suppressed, the insulin level get decreased. Suppresses appetite and slows gastric emptying, and they have to be injected twice daily, 1 hour before meals, right? And that's for 6 to 10 hours. Means before taking meal, prior to that 1 hour they can be taken, and what it do? It causes the action for 6 to 10 hours. And nausea is one of the most important side effects that occurs because of this. Then sitagliptin, which is orally active inhibitor of DPP-4, that is dipeptide peptidase, and it prevents degradation of endogenous GLP-1, right? Sitagliptin is an inhibitor of C. Sitagliptin. It is an inhibitor of DPP-4 inhibitor. And what DPP-4 was doing? It was degrading GLP. It was degrading GLP, right? So, if I am talking about DPP, let's forget sitagliptin first. DPP-4 dipeptide peptidase, it inhibits the GLP, glucagon-like peptide, and if it gets inhibited, if it gets degraded, then the blood glucose level can increase. So what sitagliptin do? It causes the inhibition of the dipeptide peptidase inhibitors, as a result of which the GLP analogs will not be degraded. That's why it has been mentioned there in the slide that it prevents the degradation, and the level of GLP-1 will increase or remain constant there, as a result of which the blood glucose level gets lower, and its dose is 100 mg a day, and it is mainly used in postprandial hyperglycemia, and there is no action on weight and lipids, but the problem is it is costly, expensive treatment. So pramlintide, it is a synthetic amylin analogs and improves overall glycemic controls, decrease postprandial glycemia, reduces body weight and anorectic action. It is well tolerated, and it is given before the meals subcutaneously, and some of the serious events, GI disturbances and less hypoglycemia when used alone. So it can be given in the combination with other drugs, and it can be used in type 1 diabetes mellitus. So apart from all the diabetes treatment that I have mentioned, diet and exercise, then insulin therapy, then oral hypoglycemic agents, all the drugs that can be used, among which we have studied sulfonide ureas, maglitine analogs, rosiglitazone, pioglitazone, right? So apart from that, there is always a need for self-care. If a patient is having that particular responsibility, and that comes with the education, right? They have to be educated properly about self-care, and self-care includes blood glucose monitoring. Blood glucose level should be properly monitored, body weight monitoring, food care, personal hygiene, healthy lifestyle maintenance. We have to live a lifestyle which should be healthy. Our diet should contain the good diet, fruits intake, green leafy vegetables, fibers should also be maintained, identify targets for control, and stop smoking. So that are the self-care method that a person can do, right? So some of the guidelines before concluding this particular lecture, I would like to mention here also about the guidelines So in elderly non-obese patients, short-acting insulin glucagon secretors can be started, but long-acting sulfonylureas are to be avoided because they are associated with some sort of serious events. So oral anti-diabetic agents are not recommended for diabetes in pregnancy, and oral anti-diabetic agents are usually not the first-line therapy in diabetes diagnosed during stress, such as infections. So in this, we have always start with another class of drugs. And insulin therapy is recommended for all both the above, like if there is infection cases or in the pregnancy. So targets for control are applicable for all age groups. So target for control is the blood glucose level. We have to reduce that glucose level which was in the higher range to a lower range. So if the patient is having the comorbidities, targets are individualized, because now if we are administering that particular blood glucose level, that can create some sort of problem in the hypoglycemic patients also. If the person is already having some other problem which can cause hypoglycemia, that can additionally be tapered down there. When indicated, start with a minimal dose of oral antibiotic agent while re-emphasizing diet and physical activity. We have to reduce that particular intake of food which is causing problems. So we have to emphasize the diet plans also, and we have to ensure that physical activity is not going to be too rigorous and it is not going to be too less also. So appropriate duration of time, it takes time actually. It is not a one thing that it will obviously come into the range. It is not that case. So we have to be really patient with this, and we have to really wait for the achievement of steady state blood glucose control levels. So from today's lecture, so what is the take home message from studying diabetes and its complications and various drugs which are occurring because which are being there in the market because of the diabetes progression, and various measures that can be taken into it, and various symptoms we have studied. So apart from that, the take home message is become obsessed about diabetes. Why? We have to become obsessed about diabetes because now we know about the complication of the diabetes, because diabetes is not even a single disease. It is a cluster of the problems that can cause to a patient if that person is having diabetes. So we have to really become obsessed about diabetes, right? So those persons who are having the familial history, they should be properly checked up, because in that cases the risk of progression with diabetes gets increased. And once diagnosed, monitoring of blood glucose levels are important, right? Always remember, uncontrolled diabetes curtails our life by 7 to 10 years. However, controlled diabetes prevents complications and does not curtail our lifespan. So we have to take every good measure, every preventive measure that can prevent the diabetic complications and diabetes, right? So with this, I am closing the lecture. Thank you so much.